Hey everyone, welcome back to our EMT review, episode 5. In the previous episodes, we spoke about a few respiratory emergencies. We spoke about pulmonary embolism, spontaneous pneumothorax, and anaphylaxis. We had one patient assessment. Now we're moving on to cardiac. In this video, we're going to be discussing ACS, acute coronary syndrome. This is an umbrella term for both unstable angina and myocardial infarction, MI. Now, this all begins with atherosclerotic plaque buildup in the coronary arteries, which takes place between the tunica intima and media, that's the inner and median layers of the coronary artery, which, of course, narrows the coronary artery. Now, eventually what may happen, this plaque may rupture, causing a tear in the inner layer, resulting in aggregation of the platelets and thrombus formation. This is going to significantly decrease blood flow or completely occlude blood flow to the myocardium beyond that point. Now, this is going to cause cardiac ischemia, and the classic signs of cardiac ischemia are crushing chest pain, right? This is often described as a dull pain, squeezing, squashing pain, vice pain, and so on and so forth, as opposed to sharp or stabbing pain, which is more likely pleuritic or musculoskeletal pain. Now, this crushing chest pain is very often radiating. This can be radiating to the shoulders, the upper back, the neck, the jaw, the arms, more often the left arm, downward towards the epigastric area. It's very important to be familiar with this radiating pain because you have some patients who may present with more atypical presentation with just the radiating pain. We'll speak about that later on. Now, usually the patient is going to have pale diaphoretic skin. They may have nausea, dizziness. They may have difficulty breathing, however, not necessarily. Anxiety and impending doom, where they feel like they're about to die. Now, if you suspect ACS, first of all, you're going to use your OPQRST to investigate the chest pain. Now, this chest pain often is going to begin at rest, although it could start with exertion, but what's most significant is that it's not passing with rest. It's not going to change with any movement or changing of position or anything like that. And this pain can start suddenly and get gradually worse, or start off severely as well, but it'll either be staying the same or gradually getting worse. Now, if you suspect ACS, you can, of course, obviously call for ALS. Now, only if they're having difficulty breathing should you give them oxygen, or if the oxygen saturation is below 94%. Otherwise, do not give them oxygen, as high concentration oxygen can lead to oxygen toxicity, which causes the release of oxygen-free radicals, which actually causes vasoconstriction, which can decrease cardiac perfusion. Now, the typical and classic treatment, of course, for BLS providers is administering aspirin. Now, the general recommendation is anything between 162 and 325 milligrams of aspirin. The general recommendation is to give the full dosage, or as close to that as between 2 to 4 baby aspirins. Here in Israel, we generally use either 100 milligram pills or actual 300 milligram pills. Therefore, you will usually give 300 milligrams of aspirin. Now, you want to make sure that you ask for contraindications before administering the aspirin. Now, aspirin is an anti-aggregant, which obviously can result in bleeding. Therefore, you want to make sure that the patient doesn't have any bleeding peptic ulcers or any recent major surgeries. Also, of course, you can ask about allergies. You want to make sure they're not allergic to aspirin. And if it's a woman, you're going to ask if they are pregnant, as this can cause issues with the fetus. Now, even if you ask these questions generally if you did your sample already and you may not necessarily have done it yet, you should ask these questions specifically before administering the aspirin. And then if it's negative, have them chew up the aspirin in order to get direct absorption into the mucous membranes in the mouth. You're going to continue monitoring the patient, continuing your taking vitals and assessing the patient, and ultimately make sure, of course, that this patient is transported. Now, there is also something known as a silent MI, which is often something that's presented this way with women, diabetics, and elderly patients, where they do not have the classic chest pain or radiating pain, and therefore a lot more difficult to identify. They may just describe general malaise, severe weakness, nausea, meaning some of the other associated symptoms without the typical symptom, therefore a lot more difficult to identify. However, it's always something makes you want to look out for, particularly with these patients that typically present in this manner. Alrighty, that's it for today, and we'll see you in the next video.